Welcome to this episode of The Donut of Destiny. I'm Claire Johns, FSCCT's Director of Membership. Today we're joined by Dr. Sotirios Evangelou and Vlasis Ninios, who will discuss the pivotal role of cardiac CT and transcatheter structural heart interventions, how it's transforming planning, execution, and outcomes. Sotirios and Vlasis, please take it away.
Hello everyone, I'm Dr. Sotirios Evangelou, a consultant cardiologist at Inter-Balkan Medical Center in Thessaloniki, Greece. And today we will discuss the crucial role of cardiac computed tomography in planning and executing transcatheter structural heart intervention. Today I'm honored to be joined by Dr. Vlasis Ninios, an esteemed interventional cardiologist with extensive experience in transcatheter structural interventions and proctoring cases globally. Dr. Ninios, would you like to introduce yourself?
Thank you, Sotirios. Thank you for this great opportunity and for the kind invitation to participate in your podcast. I think the work that you guys have put in the FSCCT is amazing, and you lead by example to other societies. As you mentioned, I work in Thessaloniki, in Greece, in a tertiary center environment, and my main interest is interventions of valvular and structural as well as congenital heart disease. Currently, we do an annual volume of over 500 procedures per year, and we try to intervene to all valvular problems, aortic, mitral, tricuspid, and pulmonary. But our main interest is intervention for heart failure and transcatheter mitral valve replacement. So we're blessed to be guided by an amazing group of physicians, and in particular by CT, which is a wonderful tool, as we will discuss in that field.
Wonderful. So, cardiac CT, beyond its role in evaluating coronary arteries, plays also a pivotal role in structural heart disease. Valvular heart disease, and particularly aortic stenosis and mitral regurgitation, affects approximately 30 million people worldwide, a number that is expected to rise as the population ages. Transcatheter interventions have revolutionized treatment, and especially for elderly population and high-risk patients, significantly altering the trajectory of heart failure. In the case of aortic stenosis and transcatheter aortic valve implantation, or TAVI, cardiac CT provides a comprehensive assessment of the aortic root, annulus, and adjacent structures. Its high isotropic resolution allows for highly accurate measurements, which are critical for procedural success. Since cardiac CT interpretation for TAVI requires familiarity with the procedure, could you walk us through the key steps of a TAVI procedure, Dr. Ninios?
Well, clearly, CT now is... We used to say that stethoscope is the tool of everyday assessment of our patients. Echo now is the new stethoscope, but maybe CT is the new echo. In that simplistic way, I'm trying to say that you feel blinded if you don't have a CT assessment. You practically cannot do a TAVI procedure. The reason why I say that is because there are so many critical aspects that you can actually assess by performing a CT evaluation of the aortic valve, the aortic apparatus, the aortic root, and also the vascular bed that leads all the way to the aortic valve, that are particularly critical. So annular dimensions and area, they're essential for selecting the correct prosthesis size and avoiding PVL, which is one of the Achilles heel of the procedure. Luckily, not anymore, but clearly it has been an issue over the previous decade. Coronary takeoff, ostial, and height, particularly if you are concerned of having a potential coronary occlusion and protecting the coronaries. Very critical is the LVOT size, dimension, and the presence of calcification. In my practice, I choose the prosthesis based mainly on the size of the annulus, but the presence of calcium in the LVOT. I would avoid a balloon expandable prosthesis in some of these cases and go for a self-expanding platform, which is more gentle to the tissue. The presence of aortic root calcification and also the presence of calcium in the iliac arteries as well as the thoracic and the abdominal aorta. So peripheral access can easily be assessed, and you can adjust your strategy depending on this. So CT is our eyes, and all the procedural planning is based almost 100% on that. Very critical for the success of a TAVI procedure.
But let me ask you, in your opinion, which cardiac CT measurements are most critical for a TAVI planning, and why?
Well, I think the annular dimensions, so area and or perimeter, depending on the platform, the height of the coronary arteries, and the LVOT calcification. Secondary measurements are the iliac arteries, but most of the times you can get away with new techniques such as lithotripsy or preparation of the iliacs. Of course, you can also discuss alternative access if the iliac axis, the femoral axis is not possible. But clearly, when it comes to the procedural success, looking into the annular dimensions and area as well as the coronary ostal height, in my opinion, are the most critical measurements.
And are there any recent updates in the field, such as expanding TAVI indication, for example, to asymptomatic patients or to younger population?
Yeah, I mean, we are all witnessing a paradigm shift with studies like the Partner 3 or the Evolute low risk. And recently, Philippe Généraux presented the early TAVI. So we're talking about younger people, younger population, and low-risk patients, as well as patients that are asymptomatic with severe aortic stenosis. Potentially, there is a space for patients with moderate aortic stenosis and reduced ejection fraction. We have some preliminary data on that field, but we need more studies. So clearly, we have shifted from the high surgical risk population, the elderly, the hopeless patient, to the everyday life patient, a young patient. I know in the States, for example, they do TAVRs in patients above the age of 65 these days, or even younger patients. We're a little bit more conservative in Europe. But a patient above the age of 70 or 75 will certainly get a TAVR because of the safety of the procedure and the very fast recovery. And this paradigm shift is evident.
And beyond TAVI, I must say that cardiac CT also plays a critical role in mitral valve intervention, both repair and replacement. It provides a detailed evaluation of the mitral valve apparatus, adjusts structures and chamber sizes and function. With the latest CT scanner that offering wider coverage, enabling functional assessments such as left atrial and ventricular volumes and mitral annular calcification. So, Vlasis, could you outline the available transcatheter therapeutic options for mitral valve disease?
Well, that's a rapidly evolving field, and it's a field that most of us that have been dealing with transcatheter intervention of the mitral valve has kind of felt the explosive nature of progress. So clearly, leaflet therapy is the leader here. So edge-to-edge repair, either with a Pascal or the MitroClip device, and more devices actually are coming in this field, is the leader in this field. But the Achilles heel of mitral interventions and the forbidden fruit of interventional cardiology, if I may say, is the replacement. Everybody wants to replace the mitral valve and create the TAVR-like outcomes. But so far, it has been very, very difficult. I know we've been doing that for failed bioprosthesis or even valve in ring, but when it comes to native mitral valve disease, it has been very, very tough. Many, many efforts have not succeeded since over 15 years ago. There is some light at the end of the tunnel. Some new devices are coming in with promise. Pivotal trials are running, and hopefully we'll have some results. But it's a very exciting field and a very difficult field.
Yes, and let me ask you, how does the degree of mitral annular calcification impact the procedural success?
Well, calcium is a double-edged sword. So we all know that a lot of calcium is bad news for the patient. So a TEER procedure, an edge-to-edge repair procedure, cannot be performed if you have too much calcium. There is a risk of stenosis or inadequate leaflet grasping. But if you have a lot of calcium, you can potentially implant a balloon expandable prosthesis, which is made for TAVI, into the mitral space. On the other hand, a mild to moderate calcification cannot provide enough anchoring for a balloon expanded prosthesis, but some of the new devices that are dedicated may find actually some space into this field. And it's actually quite interesting because the novelty and the ingenuity of the engineers of the recent years have come out with some very novel designs that are potentially promising. So we have annular devices that can dock to the annulus, and of course, calcification can be an enemy. But we have devices that can dock in the atria or devices that can dock subvalvularly, and then calcification is potentially a friend. So the assessment of calcium is very, very important, but then the decision about which prosthesis to use will come following the availability of the devices. And of course, I have to say that most of these devices are currently investigational devices.
Perfect. And I must say that one of the most critical parameters assessed by cardiac CT is the risk of LVOT obstruction, particularly in TMVR. And a neo-LVOT area, minor than 2 centimeters squared, is considered a high risk for obstruction. A study published in JACC Cardiovascular Imaging back in 2021 by Yin et al. Actually demonstrated that 64% of patients initially referred for TMVR did not proceed due to high-risk CT features like large annular size, insufficient MAC, or high-risk LVOT obstruction. So how significant is the neo-LVOT calculation? And do you have an interesting case to share with us?
Well, LVOT is probably the most common cause of excluding patients from TMVR trials these days. I mean, the size of the annulus and the presence of calcium are two major roles, but the LVOT is number one. Indeed, I mean, I'm aware of this study that almost 70% of the patients have been excluded, but to be honest with you, I feel that the actual proportion of patients excluded by TMVR trials because of LVOT and other factors may even be more than 90%, because there's always a pre-screening involved in this population. So before I submit a patient for any trial, as you know, we participate in a number of trials, we pre-screen the patient internally. And most of these patients that, for example, have a narrow LVOT may be excluded, at least for some interventions. So, recently we did a novel case. We had a patient with MAC. The MAC was large enough to provide enough anchoring for a balloon expandable prosthesis, but the LVOT has been an issue. And of course, you have to dissect, and this is where the pivotal and the key, the instrumental role of CT comes into play. You have to identify why the LVOT is a problem for the individual patient. Is it the thickness of the interventricular septum? Is it the length of the anterior leaflet? In this particular case, for example, we had a normal thickness septum, but the length of the anterior leaflet was almost 30 millimeters. So we did a procedure called Batman procedure, whereby when transfemoral transeptally inside the left atrium, and by perforating the middle of the anterior leaflet of the mitral valve, we inflated the prosthesis inside the anterior leaflet. And this way, we practically translocated the leaflet to the posterior part of the annulus, moving it away from the LVOT. And we had a fully functioning prosthesis with a free, widely open LVOT. But these are novel techniques. They may work in some patients. Clearly, we need validation in larger studies. We need more patients. We need trials and registries that can show the robustness of this data and the ability to repeat these techniques. But careful pre-procedural planning with CT will help to identify these patients and try to provide solutions.
And going to the tricuspid valve, often referred to as the neglected valve, is increasingly targeted by transcatheter therapies. Cardiac CT is instrumental in identifying potential complications before and after tricuspid valve interventions. A specific cardiac CT protocol is required for optimal imaging of right heart structures. So, Vlasis, could you share recent updates on transcatheter tricuspid interventions?
Well, clearly, there was a major development into this field. I mean, clearly, edge-to-edge repair again remains the leader in interventional options, so TriClip and Pascal. And we have some nice results. TriLuminate pivotal trial showed that TriClip improves quality of life and potentially reduces hospitalizations in a selected population. And that gave the keys to the FDA approval for the TriClip therapy in the US. Pascal is yet to come on that, but the recent PACE registry in Europe in very high-risk real-life patients showed amazing results with a reduction of residual tricuspid regurgitation in moderate or less in more than 80% of very sick patients. But I think, in my opinion, the most important development, the most significant milestone in the advent of transcatheter valve therapies in last year was the EVOQUE valve. So for the first time, we have a transfemoral tricuspid valve replacement option. So we had the TRISCENT study that showed efficacy, safety, and results that are promising, at least when compared to historical cohort from the Medicare data from surgical replacement. So EVOQUE showed the ability to eliminate tricuspid regurgitation by replacing the valve from the femoral vein. And of course, clearly CT is the key here, because a meticulous analysis for the right ventricular size, the leaflet anatomy, and of course, if there is a lead, for example, by CT, you can identify where the lead is located, if the lead may interfere with the prosthesis, if there is enough length and slack on the lead that could be trapped between the prosthesis and the tricuspid annulus and still be functional. Clearly, the femoral venous access to create some planning and reduce periprocedural bleeding complications. All these issues are very, very important, and CT is very, very important in planning and treating these patients.
So, going beyond procedural planning, cardiac CT is invaluable in post-procedural follow-up. It helps assess bioprosthetic valve function and detect complications like subclinical leaflet thrombosis. Its role extends beyond valvular interventions, of course, also to left atrial appendage closure, atrial septal defects, and the left ventricular pseudoaneurysms. So, Dr. Ninios, could you discuss any therapeutic option for LV pseudoaneurysm and walk us through a case?
Well, we have seen, as you mentioned, cases with subclinical leaflet thrombosis in both the mitral and the tricuspid space. There are low flow, low pressure systems, so anticoagulation is mandatory. And quite frequently, you may not be able to detect any valve thrombosis unless you do a CT, and then you can see HALT or HAM. It's also very important to assess the device frame integrity. For example, with some technologies like AltaValve, the frame expands against the left atrial wall. And by doing a repeat CT, you can see the integrity of the frame as well as the positioning, if it's the initial one or there's potential migration. So assessing the outcomes of any replacement in that field is very important. And of course, occasionally and anecdotally, we've all faced funny cases and difficult cases like ascending aortic aneurysm or left ventricular pseudoaneurysm. We had two cases, I remember, post-myocardial infarction, and we had to close, and all the pre-procedural planning was really performed via CT. On some examples, we had to perform a 3D printed. So we printed a model of the heart. This is quite common these days based on the CT data, and then we can actually simulate the procedure on the bench, even in the cath lab. We've done that with some of the transcatheter mitral cases by having a silicon 3D printed model based on the CT data. So we were actually doing the procedure before the procedure. And then when we went to the actual room, we were able to perform as if, we've done this before. So it's an amazing piece of technology. And I have to say that for us, interventional cardiologists, it has revolutionized. It has given us a different view, 3D view inside the heart, and the ability to perform amazing things.
Perfect. So, in summary, cardiac CT is an indispensable tool for transcatheter structural heart interventions. and especially given the complexity of this procedure and remembering the frailty of the patient population. As our discussion highlights, its role will only expand in the coming years. So, Dr. Ninios, thank you for sharing your expertise and the insights with us today.
That's a pleasure, and thank you for having me in your podcast, and congratulations on your excellent work.
Thank you.
That's a wrap on today's episode. Cardiac CT has become central to structural heart care, and as techniques advance, its impact will only grow. Thanks for tuning in. We'll see you next time.